Record. Yeah. Wonderful. And take it away.
Yeah, thank you so much. I'm Samantha Harden. I'm an associate professor of human nutrition, foods, and exercise at Virginia Tech. My background is in behavioral psychology, and as we were preparing some of these slides, and as was just shared, the field is changing over time. When I was going through grad school, I took a diffusions of innovations class because like D&I language wasn't exactly as prominent. And so some of us are being trained up in dissemination and implementation science, and some are kind of retroactively getting trained. And so what we hope to provide today is a bit more about the application of REAIM and PRISM, as has just been shared. And we're going to talk about three contextual factors. But before we get started, I'll let Tina introduce herself as well.
Thank you so much. So I'm Tina Stutz. I'm at the University of Colorado at the Anschutz Medical Campus, and I'm an associate professor in pediatrics here, but my training is actually in social work and public health. So my own research has to do with adapting parenting interventions, evidence-based parenting interventions for various marginalized communities and populations. But here at Colorado, I'm actually an implementation scientist in our Adult and Child Center for Outcomes Research and Delivery Science, which is ACCORDS. So I don't know if any of you have had the chance to interact with ACCORDS, but we're a kind of health services research center. We have a D&I science program, and we are lucky enough to be led by Russ Glasgow, who's the developer of REAIM, which is why I have now become an expert on REAIM, because I get to work closely with Russ pretty much every day. So, and so I'm excited to be here to share all of this information with you all. And I love that you're getting to do these kind of deep dives into a couple of specific models. One of the things I do here is direct our D&I science graduate certificate program, and I co-teach our context and adaptation class, and then our introduction to D&I science class. And no matter how many class sessions we devote to theories, models, and frameworks in that intro class and in the context and adaptation class, it's never enough. We never get to go into depth on anything. I feel like we do this kind of surface introduction of here's all the things you could think about. So I love that you guys are doing this and excited to help out with it.
Thanks, Tina. So our agenda, as we were thinking about what's the latest and greatest related to REAIM and PRISM, we really wanted to focus on three things. Some common misconceptions that we've heard from the field, or some of that tension or contention. We also want to really focus in on this framework and model as it relates to promoting health equity. We're also going to do a bit of a deep dive into the iterative use of the framework and how that contributes to understanding the evolution of both the framework, the model, and the context in which you're working. And then we're going to have a bonus where we're adding a little bit of information about some latest and greatest resources that you may or may not be super familiar with. And so with that introduction that was just shared about how there's never enough time, we are going to do our best to share some of these things, but please do keep in mind our re-aim.org website has lots of YouTube videos and tutorials and a lot of other information that we'll kind of talk about towards the end. We also really would like to invite you all to keep this really interactive. When we were thinking about this being, a working group, and also it's December, and how do we get all of the information out? We're really here as a resource as well. And so we're going to have a couple of pauses for parent share, and then a breakout group. And we really want this just to be an opportunity to think about the science rather than us coming in. Yes, we've been tagged as experts, but also we're all learning, and this learning is best done bidirectionally. So please do use the chat, use other features so that we can get to know a little bit more about you, as well as we're kind of just jumping right in. So the other thing that even as dissemination scientists, those of us who are really familiar with the framework and the model really struggle. We really want to re-emphasize over and over again that PRISM includes REAIM. So PRISM is a model, REAIM is a framework. The components of the dimensions of REAIM are within PRISM, but together, the purpose of them is to really guide users to plan, implement, evaluate, and sustain. And we have programs here, but really interventions in general, with a real consideration for contextual factors, and with the ultimate goal of increasing equity and public health relevance. As I mentioned before, our re-aim.org website also includes kind of learn, apply. We have example grants, we have adaptable figures and resources and tools on the website. And then one of the really latest and greatest is our prismtool.org. And we'll talk a bit more about that towards the end as well. So they're linked, but distinctly different. And we'll share a little bit more about that. I also want to share, it's an integrative approach. And just as a brief kind of snapshot, if you think about it, as I mentioned, I was taking this diffusions of innovation class, and then all of these theories, models, and frameworks came out. And if you haven't seen it, I absolutely love one of the slides and jokes that says, theories, models, and frameworks are like toothbrushes. Everyone has their own and no one wants to use someone else's. And so this snapshot is really just to show the original kind of seminal paper by Russ et al. Was in 1999. And obviously there's just been even the 17 to 24 year lag time of the uptake of a framework and really seeing it hit the literature. But for some reason, and we haven't really even done a study as to why, but PRISM was introduced in 2007. And it's only been in the last couple of years where we've been really trying to share that PRISM was an expansion of REAIM, over 15 years ago, which is incredible to think about. And there are a lot of examples in the literature of the use of either or both to help you as you're thinking about applying it to your work or potentially a grant that you're thinking about coming together. So I think from a grantsmanship perspective, people are always asking, like, what should I pair REAIM with CFR or with Paris or with this or with or EPIS or all of the different things. And my response as well to my D&I graduate course and to anybody that I would speak with, it depends, and just justify it empirically and practically what works for you and for your team. And the reason that I've been working with this framework and its expansion into the PRISM is because it's often so easy for our community partners to comprehend. It doesn't necessarily, it has enough simplicity that we can actually translate what it is that we're trying to do. So I'll turn it over to Tina to start with our common misconceptions.
Thank you so much, Samantha. So this slide, we are presenting this slide just to kind of present some information up front about misconceptions about REAIM in general that have emerged over time. Part of this was from our National REAIM Working Group, who had been, they read pretty much everything that comes out that cites REAIM. Somebody's taking a look at that if you say REAIM and trying to figure out, what dimensions are being included in studies, how is REAIM being used in innovative ways, what fields has it expanded to. And one of the things that was noted is that in some cases, there are messages that's sort of like a game of telephone where a message starts and maybe it's relevant to the 1999 version of REAIM or even a little off from that. And then it sort of perpetuates and gets disseminated through chapters or articles. And then other people kind of continue with those misconceptions. And the effect of that is that sometimes people don't recognize ways that REAIM actually could be pretty relevant to their work. Or ways that they could use it that they weren't aware of that they could use it. So if you focus on the early 1999 reference, there has been so much evolution since then. There's a new reference that I don't think we have in here, but it's easy to find. It's like the 20-year review of REAIM. If you just Google that term, it'll come up as a review paper, and it has a lot of information in it about how the framework itself has evolved. But one of the things that came out recently, this Holtroff et al. Article in 2021, was to try to capture, using a survey with the National REAIM Work Group, and also a review of literature and talking with lots of colleagues in the field who use REAIM, to identify what these misconceptions are, so that the group could start clarifying and offering really updated guidance for people who want to use the framework. So there are something like 13 misconceptions that are identified in this paper, but there's really 4 that are probably most prevalent. So one of them was that the REAIM framework is only meant for evaluation, that this is only an evaluation framework. All it's for is evaluating these very specific outcomes. But in reality, the way that REAIM actually developed and has been used over time, it's almost like a process framework. It can be used at every phase of implementation, from planning and delivery, evaluation, and sustainment, and is really intended to guide those processes. So it's not like an end of the road, evaluate your reach, effectiveness, adoption, implementation, and maintenance. It's plan for those things, and partner and co-create and assess over time. And Samantha's going to talk a lot about iterative use of REAIM, which I think is one of the best applications of REAIM, and that's relevant to this point. Another one was, I do think that when REAIM first started, because of its emphasis on the numerator and the denominator and reporting proportions, that there was this conception that it was primarily a quantitative, like you needed quantitative data to be able to use REAIM. And that was how at least some of the dimensions were operationalized by most people. But even since the beginning, it's something that qualitative methods have been really helpful with. And recently, in the last, I think 3 years, we have a publication out that is about qualitative and mixed methods with REAIM. So it's not all about just identifying these proportions and making sure you have a denominator and doing like comparisons to determine representativeness, but also you can ask questions, the how of reach or the why of implementation or maintenance, and really expand on what the original operationalization of the 5 dimensions might have looked like. And that relates to the third point, which was that there was this, and I actually remember thinking this at some point not too long ago, that you had to use all the dimensions, so all 5 dimensions are important. And that is a really compelling case that's made in the earliest articles about REAIM. The whole reason that it exists is that these 5 dimensions are all important and all equally important. However, if you've used REAIM in a study, it is virtually impossible really to do all 5 domains, or all 5 dimensions and do an adequate job of assessing them. And in some studies you can't, because some of those dimensions may not yet be relevant to what you're doing, especially if you're in a planning phase, for example, or just beginning implementation. So now there's a recommendation around pragmatic use and around partnering with your communities, agencies, systems, whoever your partners are, to determine which of those dimensions are most important and meaningful, and use that as part of determining what you're going to measure when and how. And then the fourth one is around outcomes. Again, this sort of relates to the evaluation misconception that it's not just an evaluation and an implementation outcomes framework, but when PRISM came along, which was not too long after REAIM was originally published, the contextual expansion of PRISM includes 4 domains that include contextual factors which are thought to be related to or influencing implementation. And so when Samantha was showing that bar chart over time of the frequency of PRISM being used, or at least reported in the literature, at the same time, we've really been working on the reaim.org website to incorporate PRISM so that people have a better understanding of what those domains are, how understanding what's in each domain may help you understand your outcomes in a more contextualized way, and then additional tools for using PRISM that Samantha will also highlight later. And the last thing about this article at the bottom, the Holtroff article, is if you're looking for a one-stop shop for some really, other than the website, which is a good one-stop shop too, but if you're looking for a nice table that shows REAIM domains and how they were operationalized, table 1 in that article is great. It just gives multiple examples of very clear definitions of each dimension, and then an example article in different fields that have done a really nice job of reporting on it. I am looking, oh, thank you, Becca. I can see the chat. And I won't look at the chat right now because otherwise I'll get distracted. And I'm on a timer because we're supposed to allow time for conversation. So I'll keep going. I'll plow ahead. The health equity is one of the things that we wanted to emphasize today, how REAIM is being used or could be used to facilitate implementation scientists' pursuit of research that is going to further health equity. And so as probably everyone in this work group knows, over the last 3 years, there have been a lot of thought pieces about this intersection of implementation science with health equity. And this particular figure is from an article by Rachel Shelton and Prajakta Adsul and April O. And what they came up with in this piece was 3 key recommendations for the field in general about how we should be integrating health equity considerations into all that we do if we really do hope to get to equitable health outcomes and implementation outcomes in the future. And so, you know, starting with recognizing structural racism as one key component of health inequities, and I would add to that, because of the work that I do, I would add ableism to that too, like basically structural isms that are creating inequities in access to services, the types of services that are delivered, and the effects or lack of effects of interventions and programs, access, all of those things that we know about when we talk about health equity, and then moving toward what our field could be doing to make a difference in these really structural and social not just concepts, but like realities that are creating health equities and disparities. So the first was to use this multi-level approach to select, develop, adapt, and implement EBIs and implementation strategies, and really think about structural racism as something that can be an upstream determinant that should be addressed in our interventions, either indirectly changing or working to change those things, or taking them into account and consideration when we design interventions and programs. The second is using a multi-level approach to address these things. So not just focusing on patients and clinicians, but going much higher in terms of like contextual frameworks. So all of our contextual frameworks pretty much include an external environment or outer setting type of domain, and REAIM and PRISM are included in that. I'll show you that in just a second. And then third, the importance of these transdisciplinary and intersectoral collaborations and engagement, so that it can't just be researchers, or it can't just be working in well-resourced settings with willing partners who are ready to go with our implementation projects, but really intentionally collaborating outside of that group of individual settings, agencies that can do what we are hoping that they can do and go beyond that to those who are usually not present at the table. So in the next slide, there are 2 paired slides here, Samantha. And so the first one, I wanted to take this step back about REAIM specifically. So that last slide was really about the whole field, right? Like where implementation science should be going, what we should be doing if we actually want to have an impact on health equity. And so in our REAIM work group, we had conversations about the lack of information that we actually have out there about how our implementation outcomes relate directly. Like, do we have a nice model or conceptual framework of how implementation outcomes are really related to equity? And if you think about Proctor's implementation outcomes framework, which is what this looks like, but isn't exactly, this is what the implementation outcomes framework looks like. So you've got the implementation of the evidence-based practice, ignore the adherence to guidelines, because this is taken from our survey I'll tell you about. And then implementation outcomes. So if this were Proctor's, it would have acceptability, appropriateness, feasibility, penetration, all of her outcomes, but we swapped in REAIM outcomes here. And then the quality or service outcomes from the IOM that are kind of health services research outcomes, often kind of QI outcomes like effectiveness, efficiency, equity, patient-centeredness. And then this kind of directional link is supposed to lead to the individual and population level health outcomes. So we were really interested in how people actually saw the REAIM outcomes as being related or not to any of these quality and service outcomes. Some of you may have been lucky enough to take this survey, which was painful. So if you took it, I want to thank you because the mental load associated with this survey was not dismissible. It was a rough survey, and we revised it multiple times and it was still hard to take. But you can go to the next one, Samantha. What we were really doing was basically defining the re-aim dimensions and then each implementation or each service outcome separately. And what we wanted to know was, and we had to frame it very concretely for people to be able to do this, but for each re-aim, each service outcome, we would say, if reach increased, what would you expect to see in this service outcome? And then we went through them one by one. So people matched, like they kind of rated whether they thought that that the service outcome would increase a lot, increase a little, wouldn't be changed, would decrease a little, or decrease a lot. And so I'm using this to highlight what people thought about equity without knowing anything other than the definitions of the re-aim dimensions and the definitions of the IOM service outcomes. So if we highlight equity, this is from, by the way, this is from about 259 implementation scientists, health services researchers, and then medical and public health practitioners in the US. So this is like a national survey. And what we saw was that reach and adoption were the two implementation outcomes that were rated significantly higher or further from zero, really, because we kind of zeroed it out as increasing a little or increasing a lot. If reach or adoption increased, then health equity would also increase. Everything else was fairly close to zero. One of the things we thought was interesting about that is that if you look at the yellow box, implementation adaptation, that's one of the components of the implementation dimension. We expected that adaptation would be related to health equity, since if you think about a lot of the work in terms of translating evidence-based interventions to marginalized populations or communities, there's usually some aspect of adaptation involved with that. And even when we split out our respondents by implementation scientists versus kind of traditional health services researchers, we didn't see any difference. So people didn't rate adaptation as highly as we really expected them to. And the other thing that's interesting to note is the purple bar is costs. So that's another factor under implementation. And perhaps unsurprisingly, as costs increase, equity was expected to decrease. It wasn't a huge effect. There was a pretty big range on that, as you can see in the figure. But this is where we kind of started off thinking about, this is what people are thinking now about equity, that reach and adoption are really important, and maybe the others are less so. Sustainability or maintenance should be, and I think everybody in this work group knows that, but it didn't really emerge as something that people saw as highly related to equity as an outcome. You can go ahead and switch slides for me. Thank you so much. Okay, so this paper is the last thing that I want to highlight before turning it over to Samantha. This recent paper, I hope that you have seen it, and if you haven't, it's pretty excellent. It offers some specific guidance for applying PRISM and re-aim with an equity lens across all 4 of the context domains in the PRISM/re-aim framework. And so we can go to the next slide and look at the actual PRISM domain. So this is sort of you've probably seen a lot of PRISM figures. There are a lot of PRISM figures. So here's one of them. So this one has the 4 different PRISM contextual domains up at the top. So we've got people's perspectives on the intervention and settings perspectives on the intervention. We have this external environment. We have the characteristics of the people who are involved. So characteristics of patients, of communities, of clinicians, of settings. And then we have this implementation and sustainability infrastructure, which we often think about as capacity. So the resources, the values, it could even be like the culture and climate. And then we have this interaction of the context with the intervention, the program, or the policy, and with the implementation strategies. And that leads us to our 5 re-aim dimensions as outcomes. So if you click it again for me, Samantha, what this paper comes up with, and this is just a few of the examples, is some specific actions that can be taken in each one of these kind of parts of the REAIM PRISM framework. So for example, when you are assessing context and you are trying to figure out what those contextual factors are that may be driving implementation and equitable implementation, ensuring that many perspectives are represented and that recognizing who is not at the table and who you need to invite, specifically addressing context, co-creating and adapting with communities when you're thinking about what intervention makes sense or should be developed or should be delivered, and what implementation strategies are going to work in that particular context, and not just moving something from a academic medical setting where we've done all sorts of great stuff to a place that perhaps does not have the sustainability, the implementation and sustainability infrastructure. And then when we think about these REAIM outcomes, one of the primary things is equity and representativeness across outcomes. That for each of these, it is possible, and we would really recommend assessing whether reach is representative of who it is that we are hoping is accessing and being reached by the intervention, whether the effects are equivalent or even better in groups who are experiencing disparities, because that's what we're aiming to do when we're trying to reduce health inequities. Also thinking about unintended consequences. And so perhaps like taking a strapped agency and having them implement something means that they're going to have to stop implementing something else. And maybe that something else was more important. Like maybe it was something they valued more or was of more immediate need for their population. Adaptations, again, interactions among outcomes. So this is sort of a summary of what that article talks about. It's a really helpful guide of things to think about. And then my last slide is this REAIM equity outcomes cascade. So this is just sort of a figure that's going to illustrate some very specific things at each stage or each dimension of REAIM that we should be thinking about. So for example, when we are working on adoption, and what we want is for the settings who we need to adopt the intervention to actually adopt it, then we need to be thinking about engaging the leaders, the partners, the community members, and being clear about history. So when we're thinking about structural racism or ableism or whatever it is, that can't be ignored. That has to be part of the adoption process. And then considerations like making implementation simple, low cost, low burden, making sure that our reach is getting out there, being disseminated to people who wouldn't hear about things otherwise. We need to use diverse, tailored promotion channels, make sure that access is equivalent or higher among groups who need it more, making database adaptations around our effectiveness outcomes, and then thinking hard about maintenance, because if an effective intervention is implemented but not maintained, or only maintained in high resource settings that can keep it up on their own, then we're contributing to health inequities there. So this is basically just some example actions to think about and prevent drop off and inequities at each step. Samantha, do you want to skip right into yours so that we have time at the end for discussion? Just watching the time.
Yeah, I think we're good on time. I do want to check into a couple of the chats. First of all, just because I'm obviously on this side, I've never shared on Canva. When I'm looking at the chat box, does it block the whole presentation for you all as audience members? Okay, excellent. So we can implement that change. There was a comment in the chat about as people really interested in language and in health equities, to not think that structural racism and equity are synonymous. And I did want to point and how we're including that in our models or frameworks for representation. I will point out that this paper specifically was recommendations for addressing structural racism in implementation science. So kind of as Tina mentioned, if you're adapting this version of a figure, you might change out your starting arrow for which piece of health equity that you are addressing. But that's definitely something to consider. And then Tina, there was a question in the chat box about whether or not during this survey, if someone wanted to add other or not sure if they didn't think it directly aligned with the quality of service outcomes, what were their options to kind of walk through there?
Their options were limited because And so this survey was really an initial stab at trying to understand what our field, health services research, and some practitioners think about when they think about not just equity, but all of these service outcomes. And I think we went through about 8 versions of the survey before we came up with one that people could actually answer without suffering to the point that they would quit getting through all of the outcomes, because we had to do a lot of things to it to make it more concrete. I think it was abstract what we were asking people to do. If you're interested in it, the paper just got accepted, so it'll be out pretty soon, but you can also email me and I can send you an example of what it looked like, and I can also send you what the article says. But at this point, we did some piloting where we had open-ended responses about that. And we were really focused on trying to get this as quantitative and simplified as possible to give us an idea about the next steps after this particular project.
Do we have time for me to ask a follow-up question since I made the comments in the chat?
Oh, sure.
Actually, there are 2, but I'll focus on the first one. So one of the struggles I'm having in the work that I do and others do using improvement methodology is when we talk about structural racism, it's a historical process of policy choices that were made and implemented to the disadvantage of certain people. And I really struggle to see how improvement science or implementation science or healthcare delivery science can work at a project or even a program level to deal with structural racism. The best that I see people doing is trying to deal with the consequences without changing the structure.
Right.
And I don't think that that's a long-term solution for equity in America or anywhere else. So how do you look at that as an implementation scientist? How do you deal with policy?
So I can give you an example. And this is not about racism, but about ableism, that I'm on a study where we're working on disability documentation in healthcare settings, because we know that there are really disturbing inequities in outcomes for individuals with disabilities when they go in for primary care, cancer screenings, pretty much any kind of healthcare. And while we have the American with Disabilities Act, and we actually have policies that require hospitals to make accommodations and address those disabilities, the proportion of hospitals and other healthcare settings that actually do so is pretty tragically low. And this situation just goes on because there's no teeth to any of the policies or regulations. There's no consequence for not doing those things, other than that you don't serve individuals with disability in an equal manner to people without them. And so I think this is where policy implementation is really important, because we can do a lot of things at the individual, at the agency level, at the system level, but policy is where so many of the problems come from policy, and then so many of the solutions could come from policy. So I look at Jonathan Pirtle and Erica Crable and people who are really, this is their thing, is implementation science and policy, and think that connecting with them is probably one important aspect of what we're doing. I agree with you that, in the work that I'm doing with the parenting intervention, I basically recognize the effects of structural racism or ableism, but can I do something about that in the scope of my project? Probably not, but I can look for other similar projects, or things that touch my topical area, and be thinking about policies that are affecting those parents. I think there's a lot of examples of policy being changed in places based on enough kind of grassroots citizen and researcher feedback. I've got a few examples of this from my own work around CMV screening and education for pregnant women is something that is related to child outcomes, health outcomes, and maternal health, and is not addressed in a lot of different places. And have a parent who basically was part of parenting studies and got empowered in her parent support group to go to the state of Kentucky and basically say, this is something that you should be doing, and they passed a law. So it's possible, but I think we have to kind of really aim higher.
So just really quickly, you made 3 very important statements that I just want to make sure that as we talk about this, we're crystal clear about. Where a policy exists to deal with structural inequity, the goal of implementation science is to make sure that we figure out how to get that policy implemented where it's not being implemented. And that's the strength of IS. When you talk about activating the parent or whatever it was to get something done, that's where, and it's not really on here, that's where community engagement science becomes really important so that you can gain the trust and partnership of those patients. Not really well covered, in my view, by anything I've seen in these figures. And then another discipline comes in, which is critically important, again, isn't really addressed very well, that may not need to be by this framework, which is how do you organize? Where does Marshall-Ganz come in? Where do you learn how to press for antiretrovirals to be available for people in Africa? And that's an entirely different discipline, right? With an entirely different way to structure your work. So as long as we're clear, it's equity, structural inequity, where there's policy that needs to be implemented. That's the strength here. Where we're talking about engaging people in smaller projects to deal with perceived health services research demonstrated inequity, that's really important as long as it leads to action, which involves organizational theory and Marshall-Ganz and people like that.
And I agree with you. And I also think that when you think about implementation strategies and health behavior change, clinician behavior change, whatever it is, implementation science doesn't, I mean, other than our TMFs, many of which are drawn from other places, like nobody's really an implementation scientist. Everybody's something else. And so as a field, I mean, we're a transdisciplinary field. So if our interest is in policy change in another country, for example, then it's incumbent on somebody who's an implementation scientist to know that they need people, you know, they need community people, they need community engagement, they need to interact with policymakers and decision makers, and they need people from other sciences to be part of this. Like I recognize I know a certain about a certain amount of things, but if I'm doing something outside of that scope, I find that to be one of the really nice things about implementation science is that I can find people who are interested, who may not be implementation science oriented, but have that expertise. So I think that the kind of transdisciplinary nature is something to think about and emphasize as well.
Thank you.
Love this. Yes, love this discourse, and it actually cues it up. One thing before we wrap, or I can share afterwards with Becca, is a policy implementation science paper that was really powerful. And the other thing that came to mind for me is the 9 P's, like that it's pills, programs, policy, practice. Like, so you might be thinking about your EDI as a direct education little p program, but that's within a larger practice that will eventually inform policy. And we hadn't connected prior to this, but it kind of sets me up really well to talk about what I want to talk about, which is the iterative use of re-aim and de-implementation science, only very briefly, but it directly links to policy. So if anyone, I'm just curious, maybe you already know. So if someone wants to try to figure out, if you already know, maybe don't share, but if you're thinking through why it might be, would anybody like to take a guess at how the right turn on red policy came into place, where we could turn right on red at stoplights? Anybody have a guess they would be willing to unmute and share? Maybe use contextual clues like the pictures on the slide. All right, I'll share. Okay, so just to be on time. So about 30 years ago or more, many of the cars were in no way efficient. And one of the ways policymakers thought we could keep cars moving was to implement a policy where you can turn right on red in places where you're turning right, where you're driving on the right, and left turn on left in other countries. So they did this to keep cars moving. so that we could hopefully reduce emissions. And does anybody know that right turn on red results in the highest proportion of pedestrian deaths? So we have this policy to address one issue, and we have not considered the unintended negative consequences. And when my dad told me about this, I said, well, Dad, I have to now include this in my D&I class because it's such a rich example of this other meme that I love. And it's firemen, which my dad was a fireman, he's retired, but it's firemen facing away from a burning building. And it says, we're here from the university, we're here to help. And so many times we're sitting there, you know, trying to address something that's not the actual problem. And then furthermore, once we get really comfortable, because behavior is so hard to change, just like policy is so hard to change, now that our cars are different, how do we start to implement these changes and then ensure people even know about it and all of the potential unintended consequences of just simply de-implementing something that's not working? So we have to be nimble and rigorous and systematic when we're thinking about our version of a right turn on red evidence-based intervention that exists and is maybe not working, or a way that you're trying to increase the uptake of your intervention, or the sustainability or the scalability, whatever it is that your next best research question is trying to answer. How are we considering evolution and context? And so, as was mentioned and is in the chat box, you know, we have this 1999 paper that had some preliminary, you know, guidance, because so many people were just reporting on efficacy and effectiveness. And we know that this was couched within a greater context. And so with our 20-year review, we were able to talk about we're adapting. And so just like frameworks are adapting or policy should adapt, maybe you're finding that your context is adapting as well. We are kind of tight on time, as probably expected. So instead of doing any breakout right now, I just invite anybody to use the chat or to unmute what was an unexpected evolution within your context. So maybe, you know, your grant was released on July 1st and you were ready to go. You had all your IRB documents and you had this perfect plan. And then there was some sort of evolution within the context that you were not expecting. If anybody would be willing to unmute and share, or to share in the chat box. Yeah, I like this. The right turn on red, they could have deadly consequences, right? Like this is what we're talking about with our structural inequities. Again, sorry, I'm trying to be not rushed in my life, and it's not translating because now we only have 14 minutes to get through the rest. So I will just go forward. But what we usually see in a prompt like this is very people driven, which also relates to what Dawn was talking about, process. You know, when you partner with someone in particular and they leave for parental leave, or they get promoted, or they leave the system, and you said, well, that was my linchpin into this specific context, but then there's an evolution that happens, or there's a policy released and now that needs to be implemented, or something that you have to be nimble and be able to respond to. And what we propose is to iteratively use REAIM through an assess, plan, do, evaluate, report, or ABDR process, very similar to PDSA and all of those types of cycles, where you're thinking about your REAIM outcomes. And this is before, during, and after your intervention. So and as Tina mentioned, it is a lot of work to try to assess, let alone intervene to improve each of the dimensions of REAIM. But depending on the research question you're asking, you might want to focus in on intervening to improve just one or maybe two of the dimensions, and you're just assessing the other dimensions. But by thinking about an iterative use of reaim, you're able to, within the context of your actual study design or your research question, be a little bit more nimble to say, this intervention that we planned or this implementation strategy that we planned to improve capacity or confidence and whatever you're trying to improve, it's not working. So we can even take action and reflection and change and then watch the trends in our data. I'll give one example related to reach with the iterative use of reaim. So we, in one of our interventions where we were trying to recruit individuals who were pregnant, who had obesity and were from low-income households. And we, if they met the criteria for their gestational weeks of gestation, we had an electronic medical record ping the physician to then prompt the patient to then speak with our recruitment person who was in the next room on the way out during the pathway of care. And we thought the electronic medical record reminder would be our best place because, of course, every physician is checking that out before they have the interaction with their participant. But as many of you who are either physicians or partner with physicians, there are so many different things and screens and slides that you're trying to get through. Our nurse practitioner, who was part of our participatory research team, said, you know what, forget the electronic medical record reminder. Let's place a colorful note right at eye level on the door that pings the physician and says, this patient is eligible. And it's just a color. It doesn't say this patient is eligible. And so we know what the cue to action is. And so in that way, we were able to change our recruitment. We didn't have an IRB amendment or anything. It was just, when a physician missed the prompt, is there another way to prompt them so that we don't lose all of that reach of our potential participants? And so if you haven't seen this paper, I hate to fully self-promote, but we spend a lot of time. And of course, we can look at the figure and say, here's what doesn't work, but we actually did this like 2 days before Christmas, like years ago. And we're like, how do we show that it's bi-directional, it's iterative, you're getting feedback from all of your multi-level engaged partners? This isn't just, well, this isn't working for me. It's how do we think about what isn't working, what might work, and then implement that. So we're not waiting to the end of our 5-year research program to then implement the change. So this paper not only has this figure, but it also has a table with specific questions you can ask within your participatory team to really guide the process. So I'm talking a lot about integrated research practice partnerships, where you're not just having your end user or patient or participant involved, but you have all of these different individuals who may be involved so that we can, this is the FRAME, which is the Framework for Reporting Adaptations and Modifications Expanded. It's a lot, right? As has been mentioned, we have so many theories, models, and frameworks. We can sometimes overwhelm folks, but it's a lot because it is a lot. To change an individual's behavior is a lot of work. To change the behavior of an entire community or context or setting is a lot. And as you're working and things are evolving over time, sometimes we think about what's the impact of seasonality. Well, when you're running something over time, what's the impact of everything? And we want to understand our outer settings. We want to understand our infrastructure. We want to understand our resources. We want to understand the individuals with whom we're partnering and what do they value and how can we help our intervention fit within their pathway of care or their daily life so that they can start to de-implement things that don't work. But FRAME allows you to really think, when did the modification occur? Were the adaptations planned? Who did it? And you start to get a little bit more of the data. Again, what I shared about our post-it on the door, that was anecdotal. We never reported that. We never said this helped us increase our reach. It was kind of an on-the-fly, in the space thing. But when you use FRAME or you use iterative reaim or some way of trying to capture the in the field adaptations, particularly a priori, where you could say, if this happens, here's our strategy 1, strategy 2, strategy 3, and then that can start to become some really cool advancement of D&I science. And so so that's where we start to think about, like, what's the generalizable knowledge of my process to help this intervention actually get its uptake and sustainability. So also, this is a lot, and sometimes I need to simplify, and there has been a recommendation of a table as well, where you can have your timing of your adaptation. Was it during in planning, during, or in your sustainment phase? What was the focus of the adaptation? You may also be familiar with Chambers and Norton's adaptome, where it's like there's different levels of adaptations and what adaptations. What I hope you hear from this iterative use and this capturing of adaptations is really that adaptations are going to happen. Expecting everything to go as planned, or really having control in the real world, right? We've all been saying in the real world, but we still want to hold on to our really, explanatory and controlled methodologies. Pragmatic is not synonymous with, oh, I'm just going to figure out what I'm doing today and go with it. We still need to be empirically and practically justified. And we use subjective data and objective data to determine what is the change, what is the adaptation, what strategies might help my community better or more. And so when we use a framework or a model to guide these adaptations, they can become a bit more systematic, a little bit more researchable, so that we can create generalizable knowledge that might say, okay, I work in physical activity promotion, but the same process could apply to tobacco cessation. And so just being really nimble and thinking about these types of things ahead of time, so that you can have your plan with your team and know that you have the resources to achieve that. This is one of the ways we're using REAIM and PRISM really iteratively to understand the adaptations that are happening. I do want to
Samantha, can I just interrupt you and ask you if you could answer Claudine's question? It's a great question from a student who's working on her dissertation, and I'd love your collective thoughts on that.
Okay.
Sorry to interrupt you, but it's so important to give feedback when we can.
No, please do. Yes.
I'm typing an answer to it right now. Is that okay, Karen? If she keeps going, but I'm like in the middle.
Totally fine. Thank you.
Okay.
Yes, and we can absolutely revisit. I'm going to blaze through because, like I said, this is all available on the website, as well as a couple of YouTube videos. We're trying to make them like a little bit more podcasty. But for those of you who have not visited yet, we highly encourage you to visit our prismtool.org. And it is an opportunity to understand iterative PRISM, so iPrism web tool, where we have a quick start guide, and we have the ability to use the iPrism web tool in 4 simple steps. You can complete an assessment of your evidence-based intervention before, during, or after, in your planning phase, your during phase, or your sustainment phase. You can use this iPrism tool with your participatory team. So you can all be independently coding, or you can do it individually, or you can do it as a team to say, where are we? What are the elements of our intervention? What needs to change? I know I'm going really quickly, but my point is, it has all of the REAIM dimensions and all of the PRISM domains and a couple of prompts. And then what we're really excited about is it gives you some data, some figures, so that you can use data-informed decision-making to apply REAIM and PRISM iteratively. What I mean by this is, if 3 months into your intervention, you ask your team to do the iPrism assessment, and you say, how are we doing on, for example, on this patient and community perspectives of the intervention. And this figure on the right side of the screen right now is showing that that's really low. That might show that's where we need to invest, perhaps more time, more resources, maybe a new implementation strategy, something to try to get, like, this is the big gap of this intervention at this time. And on the left side of the screen, the adoption is looking pretty low. So that might go to something like what Tina mentioned, where if you're only partnering with settings who are keen to uptake your intervention, you're not getting some of the nuance of what a setting needs in order to improve the adoption. And the final thing that I really want to highlight is the guidebook to the pragmatic and iterative use of PRISM and REAIM. You can take this tiny URL or use the QR code to head over to this compilation of prompts, definitions. This could really help, as was mentioned, there might be students on the call. So as you're thinking about using a framework and a model, really starting to get confident in its application. We do not have time for our 15-minute breakout. No kidding. We planned for a 15-minute breakout. Okay, so Claudine said this, the response Tina already shared was helpful. With that, I'm so sorry we're so close on time, but I'd love to hold space for the last 2 minutes for if any of these prompts are jumping off the screen at you, or if there's any final question that you'd like to share.
I have to say that was so helpful in terms of how REAIM and PRISM are connected. Some people have said, oh, PRISM has replaced REAIM, and I knew that wasn't right, but I didn't quite, I knew they were both sort of still relevant, but I didn't know exactly how you saw as developers their interaction. So that was enormously helpful.
I think that is right at the beginning, Samantha said it's a dissemination problem, you know, and I will say that even, you know, PRISM's existed a long time, and I frequently have used CIFR and REAIM together instead of PRISM and REAIM, just because I knew CIFR, I really liked it. It had great tools available on its website. So reaim.org has really also has lots of good tools and has really been developing those as well, and trying to like find more ways to make it easier for people to use PRISM and REAIM together. So I think you can, I mean, I don't know that this is actually the party line and we're still recording here, but I think you can pull them apart and use, you know, REAIM dimensions with really any contextual framework you want, or a process model. You can throw like adapted in there, and, you know, just the use of multiple frameworks I think is helpful. And for Claudine, I think my biggest recommendation always is use the thing that makes the most sense to you. And if you have someone you're working with who has expertise in a specific framework, it's not a bad thing to use that one because they can help you, you know, especially in dissertation work. Going off into your own and having to learn all about a framework and how to apply it can be really challenging. And so if you have people to draw on who are familiar with a specific one that works with what you're doing, you can always later decide you want to switch gears and, you know, focus on the health equity implementation framework, for example. So we try to have our classes not get super hung up on which thing they choose, but just figure out which one kind of fits what they're doing and they feel like they intuitively understand it and they have the resources and examples available that they need.
Thank you so much.
Sure.
Thank you for providing such a good case example of a student project trying to apply this in real time, Claudine. So I'm going to close us out. We're past time. I just want to thank Tina and Samantha for joining us. This was really very helpful. Tons of references were put in the chat and on the slides, and we'll make sure we get everything out to you all in terms of a recording and a follow-up email. So thanks everyone so much.